So let's go ahead and start. It's 11:05. I will pass it over. I think, Alexis, are you presenting first or is Michael?
I'm going to, because it seems like mine's kind of preparing to go, and then hers is more like once you're there.
Excellent. Okay. Well, I will pass it over to you to introduce yourselves as well, and feel free to share your slides. So the floor is yours.
Okay. Thank you for inviting me to do this talk. It is something that we run across all the time. I will say, and I'm saying this like multiple times, what I am presenting on is actually something I was not part of developing. Other people developed it. I just shared it with the group when someone asked, and then Steve asked me if I would talk on it, and I agreed. But I am not taking credit for this. It is just something I am presenting the information on it. And basically, between Alexis and I, we've kind of broken it down. So I am going to be talking about things you can do, or a form that can be filled out ahead of time that people can bring with them if they have to go to the emergency room or into the hospital. And then Alexis is going to talk more about, once you're kind of there, how can you set things up so that they have a positive experience in the hospital type of thing. So
Mike, can I interrupt just to say that I remember the reason I invited you specifically. I was so excited when you presented that passport idea. I don't know why, but it's like, oh, that is so freaking cool. So I thought that it's so perfect for this group to have something very practical like that. So thank you for that.
Yeah, no problem. And I will be talking about the passport. It's just, as I said, I did not develop it, so I don't want anyone to give me credit for it. Just a brief introduction to myself. I am an associate professor in the Department of Psychiatry at Emory University and have been working at the Emory Autism Center since 1991. I've actually been working in autism since 1988, mostly providing treatment, but ABA treatment within natural environments, doing more NDBI strategies, but over the years have kind of switched into diagnostic and training of future BCBA. So that's a lot of what I'm doing, is piloting some remote diagnostic programs so our state can identify kids younger and younger, so that we are getting away from the people are concerned at 18 months, 16 months, but they're not diagnosed till 4 or 5. So hopefully in the future, we'll have more information on that we can present with this group. Okay, so I am presenting my slides. I hope you all can see them. Basically, as I said, this talk is going to be on really preparing hospitals for individuals with autism, the medical alert passport. And basically, this passport was created at the Emory Autism Center. The leads on it were Sharon Hines, who is the program manager of our behavior supports program. And she really does a lot of training with parents of all ages on embedding ABA within their natural home and community activities. Tony Thomas, who is the program manager of our My Life Adult program, which really does social communication interventions using the Emory campus as their classroom. And Holly Abernathy, who is now an LPC, who works with our counseling program and provides counseling and then support to the adults that are in the My Life program. And Susan Brasher, Dr. Brasher's in the Rollins School of Nursing. And she and Holly actually came up with this idea and then kind of brought it to the Autism Center on how can we develop this to help people. And it's been adapted from the UK's National Autistic Society's My Hospital Passport with permission from them to adapt it. Basically, it was created really in March and April 2020 when COVID started, and the hospitalization rates were going through the roof. And we had a lot of people contacting us, ending up in the hospital with severe COVID, and they were having issues. Some of it was related to hospitals not allowing visitors or caregivers in the room. So they were taking this individual with autism into the rooms with COVID by themselves, and they weren't sure how do you work with them, especially if they were nonverbal or minimally verbal. And once they were in the hospital, kind of how do you calm them down? So the EAC developed what's called the Medical Alert Information website, which gave information to the community on things you can do. The links to all of these are at the end as well, and I will send the slides to IDEA so they can share them with you guys if you want, so don't feel like you have to copy it all down. And basically, this medical alert passport was really, it's a one-page summary of the unique needs and supports of this individual at a glance. And it is meant to be completed ahead of time and updated ahead of time so that you have it and you can bring it with you when you go to the hospital and you can give it to them. It's not meant to be completed as you're going to the hospital to get this done. It was really created by reviewing research in the internet for what was out there. You know, we knew there must have been something out there, so why should we recreate the wheel? And then, as I said, they ran across the National Autistic Society's My Hospital Passport and contacted them and got permission to adapt it. They created a one-page handout, and I'll be going through kind of the different sections of it so you know what we are asking people to fill out. And then they also have an accompanying note guide that really says what should go in each of these sections. Here are questions to think about. Here's what you really need to do. And really to know this information you're giving people, doctors and nurses are not going to be spending hours with you. They are coming in, they're quick, you know, they're having things. This is going to be information for how they can communicate with you and help you in the best way possible in that short period of time. And it, as I said, it's meant to be included in your personal medical binder that you bring with you. This is the medical passport. I should say the binder has things in it like your, your name, date of birth, blood type, immunization records, any kind of diagnosis, reports you have, living wills, advanced directives, medical power of attorney, DNR orders. So it's all organized together. And, you know, the medical passport is one page, and then the guiding notes is there, and I'll be going over both of those here. So really the first part of the medical passport is just getting information, your personal information, name. Also, what do you like to be called? So that they're not calling you, you know, Michael, when you really like to be called Stephen, or they're, you know, something like that. What is your nickname? Who is the caregiver with you? We were also developing this so that it could be kind of like my adult or my child needs someone with them in the hospital. So you just don't take them and go by themselves. They're going to need someone there to help with all of this, to really try to get past that. There's only one person allowed in a room at a time. We also asked them to put any medications they're on, as well as past medications they didn't respond well to, so that the hospitals wouldn't be prescribing those again, and then kind of setting it up. Also making sure the hospitals knew who was tracking their medication right now, who was their prescribing physician, and how could they contact them in case there were other issues that came up, so that they would need to know what to do with this medication, or how do you react to this kind of side effect, and all of that. Then parts 3 and 4 were really based on how do you communicate? How do I, as this individual, communicate? Do I talk? Do I use an AAC device? Do I prefer pictures, or, you know, pointing to things? If you give me choices, I'll point to them. Or do I prefer that the caregiver that's with me answer these questions? I'm giving permission for that. Also, kind of that, like, you get this all the time when you go to the doctor, like, how do you like information? Do you like it read to you? Do you like to see it? Do you like to read it? You know, how would this patient, how did they respond to communication the best? So, you know, can they ask questions to them and they will respond? Or do the questions need to be very short and specific? Do you prefer having pictures and symbols associated with text? You know, what is the best way for me to communicate, or the nurses and doctors to communicate the medical information they have to with you as a patient? And again, I should say this was geared more towards adults that are seen as independent, you know, agents, and not to rely on someone else if they don't have to. Also, because, you know, individuals with autism a lot of times have high pain thresholds. You know, writing down, how do they experience pain? How do they communicate pain when they are in pain? Because it may be different than how other people do, or how the nurses and the doctors are used to people communicating. So really be as specific as possible. You'll notice the boxes are small, and they developed it that way on purpose. So you couldn't write a book about each thing, but it's just, these are the things you need to know to make this visit as positive as possible for everybody. Then the fifth part is kind of a sensory and environment. So what are things that bother them or cause them distress and anxiety? And then how can you help me stay calm or cope with these things? So again, what are my coping strategies? And I believe Alexis is going to go into more like a coping plan, which is similar to this, but really focusing more on that. And writing things, what makes me happy? What are other important things you need to know about me? Or, if you're not feeling well, or you're in pain, does food make you happy? Does it kind of calm you down? Is watching a certain show, is being on your iPad doing that? Any comfort items that can be brought from home? Routines, are there specific routines that if you don't do it may agitate you? And really getting this information again across to people that may not know so much about autism, or having worked with an individual on the autism spectrum before. I know in Atlanta during the main COVID push and the increased hospitalization, they were pulling nurses from all over the place. It was like whoever kind of showed up to work were dealing with the COVID patients. So they may have had nurses that had never had experience with autism before, or doctors as well. So really making sure that this information is there so that everyone was aware of it. And then also, more safety issues. Do they have pica? Do they elope? Or do they have any aggressive or self-injurious behaviors? And then also describe what those are, and then what works to kind of ease those things going down. So again, it was something that was developed to really be one page, filled out before, updated as you need to, and you bring with you when you go to the hospital. So you can hand it to a nurse, you can hand it to a doctor, and it becomes part of your medical record, so everyone has it. And we ask people to really put it in the first page of the medical record. So it's not just the, how's your heartbeat going and all that, but this is there so they can read this and they can go through and all of that. Some of the information we've asked people to include is, do they have favorite TV shows? A lot of times, I don't know, again, Emory they must have some deal with HGTV, because every room you go in, HGTV is on, but what if that's not something you like? Is there another channel we can get to? Are there any other sensory needs or avoidances that you didn't mention before? How can you put that in? Any spiritual or cultural issues or needs that they need to be aware of so that they can go through, because not all of that is always in your record, type of thing. And then do you need help with self-care things? Would you need help dressing, putting on gowns, brushing your teeth while you're in the hospital? And really getting it, again, giving as much information as short of a time as possible. And then making sure that people knew about it, so that anyone who came in contact with this client while they were in the hospital have this information and know what to do. Again, this was made specifically for COVID, but we've had people report that they've used it for other things. They just use it on a day-to-day basis, and they make it. We sent it to a contact we had at Autism Speaks, who I guess she sent it all over the place and said, it's good because Texas was contacting me saying, what can we do? And Arizona was contacting me. So I just gave them your information. Hope you don't mind. The hard thing is we're not really sure who is using this or where it's going, because Emory's thing doesn't keep track of that. The guidance notes, as I said, are just a reminder of what to go in it. This passport, it really has big reminders. Update is needed. Keep 2 to 3 copies. Include these other things in there, and then provides guidance and questions that the individual or their caregiver who's filling this out is asking, so that they can put it in there so that people know. And that was really good to have Susan Brasher, Dr. Brasher, involved in this, because as a nurse, she kind of knew what are questions that nurses have when they go in the hospital. I always know when I'm in there, oh, I wish they knew this or that, but I don't think about it on a day-to-day basis, where she really knew ahead of time, this is what people need to know. And then we have links to all of it, a map, which is a PDF that anyone can download, the guidance notes, as well as the medical alert information website that really goes through a lot more information on things when you have to go to the emergency room or you have to be inpatient for people. So that's the map. That's really how we prepare individuals and hospitals to go in to accept individuals with autism. We do a lot of nursing and pediatric and psychiatry resident training. And this is something we have embedded into our training so that they know about it, so that they can suggest it to families as well, in case families don't have this type of information available to them. That's all I have. And I guess Alexis can go unless you have questions on it now, or you want to wait. I'm free either way. It might be better if you hear Alexis go, and then you kind of see how these two things go in together. So
let's go ahead and flow into Alexis, and then we can save questions for afterwards.
Okay.
Sure, I'll be happy to take it from here. So let me figure out how to share my screen.
Michael, I think you have to stop sharing.
Oh, it's gonna let me take the reins regardless. All right. Let me make sure I can share the right screen. Of course, shared the wrong one. You would think after 2 years here that this would be second nature, but
we love your dog.
Bear with me. I always forget that that's what's happening on my background. Oh, thank you so much. So I'm Alexis Pavlov, and let me make sure, is the screen that I am sharing the one in presenter view or the other one? The good one. All right, perfect. So I am an assistant professor at Emory in the School of Medicine. However, I primarily operate as a clinician over at the Marcus Autism Center. I am a licensed psychologist in the severe behavior program. We're primarily working in the intensive outpatient program. Within that, we see children who have a diagnosis of autism or a related developmental disability who engage in fairly significant challenging behavior. All of these kids are coming from the emergency room, coming from inpatient stays, really the last kind of attempt at intensive treatment before residential is considered. And through this program in the last 2 years formally, we've developed a hospital consultation liaison program where referrals come from the emergency room of children who are admitted in a behavioral health crisis, either in the emergency room or an inpatient, and provides a clinician like myself to consult with behavioral recommendations focused on patient safety as well as medical compliance. So I've been within the walls of Children's, kind of getting to know our patients and the struggles of our hospital doctors and nurses and techs working with this particular patient population. So I'm going to follow Mike and kind of talk more about, we know that there's a patient coming and they have challenging behavior. What can we do to mitigate the results or help us prevent the likelihood of a crisis? So quick Autism 101, I'm sure this is not news to any of you, but challenging behavior is not a core symptom of autism, yet it's a result of some of the symptoms associated with the diagnosis. You've got your difficulties with social interaction, communication deficits, and the increased likelihood for stereotyped or repetitive and restrictive behaviors. And those deficits can manifest themselves in challenging behavior in a number of ways. So let's take a kid who has difficulty with social skills, might engage in challenging behavior to avoid social interactions. We've got our kids who may be minimally or nonverbal, and those difficulties with just your generic exam can manifest themselves in aggressive or self-injurious behavior. Our kids that come through the door with repetitive interests, Maybe we've got a patient who is attached to the iPad like glue and cannot get an MRI with that iPad in their hands. One might engage in challenging behavior when that repetitive or restrictive interest is interrupted. Again, difficulty with communication. They might not be able to communicate that they would like to keep a preferred item or would like to gain access to attention. And so challenging behavior is a fairly effective form of communication to say, give me that, or I don't like that. So all of the challenging behavior usually serves a purpose for the child. There's a reinforcer, and that's your most important tool in figuring out what we can do to mitigate challenging behavior or prevent it from occurring in the first place. What is a child trying to communicate when they're having, precursors to aggression or self-injury? And different children may engage in the similar behaviors for very different reasons. I think this is what I've kind of focused on in my time in the hospital is when you've seen one patient with autism, you've seen one patient with autism, and they might not present like the next kid who's going to walk through the doors. And challenging behavior is sometimes the easiest way to communicate. And so strategies that are designed to understand what these children are trying to say are most effective. Because if we can identify what a child is trying to communicate, we can likely avoid problem behavior from escalating. So hopefully that wasn't news to you, and I rushed through that so we can kind of get in the meat of the presentation today. So I'm going to talk a bit about mitigating challenging behavior. This is a very blurry, awful copy and paste job of what we refer to as a coping plan. It's similar to what Mike was going over with the map, but it was designed initially in the children's hospitals for day surgery services. Day surgery, you don't get the same rush order of a child coming through the doors without a lot of background, but there was some time to develop a coping plan for a patient coming into surgical services to make it less likely there would be an adverse event or, a burst of challenging behavior that would require additional sedation. So these also go over similar types of things, but it is documented inside the EMR so that every patient coming through the door that has a coping plan will have an alert that comes up for that practitioner to then read the coping plan, to at least acknowledge that you've seen it. And now these are kind of present across the system. But what they cover are different levels of behavioral, let's say, intervention or prevention. So there are essentially 4 different types of levels of support. The first one is prevention, and that's what I'm going to be focusing on moving forward. The rest of these are, let's say, more time intensive. So if we have prevention, we typically don't have to go down the list. With behavioral intervention, as you all know, with these kids who have challenging behavior, it can be really intensive. It's focused on long-term improvement, but can take some time. And so while a child is in the admission of a hospital, that is not the time that we're going to be able to intervene on challenging behavior. It's the time that we're trying to avoid it or decrease the likelihood of the intensity increasing. So let's focus on prevention, which is how do we avoid challenging behavior in the first place? So there's a couple of really, I think, strategies that I use most often are the ones that I'm going to go over, and one of which is arranging the environment. So from this picture, up at the top, the hospital is not a fun environment for most children with autism because there are so many people moving in and out of spaces. There are loud noises. There are routines that exist in the ED that don't exist anywhere else in their lives. So this might be the first exposure. There are needles. There are restriction of preferred items. Maybe their preferred person isn't there. And there's a lot of moving pieces with different people coming into your environment. So one of the things that we really have focused on is, can we strategically room patients? Is there an option for a behavioral pod in an emergency room or a patient's room that might be away from exits if a child has issues with elopement? Can we move furniture in and out of rooms that might be problematic? So if there is a child that engages in a lot of disruptive behavior, do all of the machines and glove boxes and hand sanitizer need to be in the patient's room? Or can we remove those items to make it a less environmental triggers present in that patient's room? For elopement specifically, aligning furniture to define boundaries has been helpful so that you don't need staff of 5 people to be able to block exits. Now you're able to use the actual furniture in the room to designate what boundaries might be present for that particular patient. And then station staff at appropriate locations. I think elopement is a big one for facilities that are non-locked, like our children's emergency rooms and inpatients. There is not an option to really lock down the unit, given that it's not an inpatient mental health facility. And so really strategically placing furniture and staff can be a really great use of resources without having to put people at risk for injury. All right, the second one, and this is my favorite, is allow the kid to have the stuff that they want within the limits and confounds present at your particular location. Having access to preferred items, and hopefully you've got something like a map or a coping plan to lead the way, but these preferred items can often help reduce the likelihood that problem behavior will occur when it's related to restriction, but can also serve as a distraction. A lot of the questions I get from practitioners come from not being able to identify what preferred items are. And my recommendation is always to think outside the box. So sometimes our kids with autism have unique preferences or interests, and the very best reporter of those is a caregiver. They're going to be the first one to say at home, they sit around and play with a hanger all day. Might not be best to have a wire hanger in a hospital, but we could probably get something analogous, right? Some kind of fidget tool or something that can serve the same purpose as a hanger. An iPad, if we don't have access to lots of iPads, is it possible to get the child a TV in the room that they can control and put it on a preferred video? There are preference assessment tools that are out there to help individuals walk through what might be able to identify a preferred item. I'd be happy to share links with you on that, and all those resources are available free on the internet. But sometimes they can help us identify, especially when a child is minimally or nonverbal, what preferred activities might be available for that child. One of the important things that I always consider is whether or not that particular child likes things like attention. I think we traditionally, as providers who work with other people, use attention to connect with our patients. And sometimes that's actually an aversive experience for that child with autism or that individual. And so knowing whether or not your attention is valuable or aversive is sometimes really easy to identify if you walk into a room and the child is immediately asking you to leave. Those are also good things to know when you're trying to pair positive experiences with a hospital environment. Responding to requests, typically, if you can do it, you can do it within the confounds of a hospital. This does eliminate lots of fun things like, let's say, going outside and riding a bike. Well, that's not available in the hospital. It's unsafe to do a transition. But if you can, providing and honoring reasonable requests is important to reduce the likelihood of challenging behavior related to restriction. If something is not available, I try to encourage people to eliminate bargaining, where it's a delay that keeps on being delayed. So a good example of this is, no, mom's not here right now, but I bet you if you're good, she'll come back later. You have no control over mom's arrival or non-arrival to the hospital. Don't provide contingencies that are either unclear or cannot be reinforced. And it's a typical "that's unavailable" statement usually hasn't been paired with a lot of aversive experiences for most kids, because it's kind of just a unique thing to say, that's unavailable. But I encourage just kind of rote language so that you don't get into that kind of bargaining back and forth. And really, if we have a good reason why the patient can't have something and it is medically necessary that they do not have that thing, or is it because it's the thing that we usually don't let them have? I think that's a really important consideration, and I'll talk about that a little bit later. A really big one is to limit all non-medically necessary demands and really providing required demands of the patient. A really good example is I was working with a patient in the emergency room who, after speaking with a caregiver, spends all day, every day at home fully disrobed. Not ideal in an emergency room, right? Not ideal to have a kid just totally naked in their room. But at home, that is what the natural environment is. And prompting this child to put on a purple gown over and over again was resulting in many instances where the child was now putting others in danger, as well as themselves in danger, and ending up in chemical and mechanical restraint. So we don't typically let a kid kick it naked in a medical setting, but limiting that demand of asking him to put on a robe and simply closing that patient's door with a sitter inside dramatically reduced the instances of restraint. And then that child was able to receive medical care, was able to go to an inpatient location because he hadn't been restrained. And so that is a demand that we put on kids that maybe we don't necessarily think of as a non-essential demand. I know which strategy to choose, and it's going to be individualized for each kid, but my recommendations is always to speak with a historian. And this historian might be the individual. You might be able to get information from that individual, what they like, what they don't like, what helps them in a situation where maybe we're going to have to do something like a blood draw or check vitals, what would help them feel more comfortable in that particular scenario. But the caregiver is really a very great historian for things that go good and things that go bad. And my best experience is to really listen to that caregiver and try to implement as much of what they know into what you know about the child. Obviously, the tools that Mike and I have talked about, those are really important. Creating a system of alerts for those patients prior to their appointment when possible is really helpful. Again, we have an alert that pops up in their EMR, but if a parent doesn't have access to, bringing a medical alert passport with them, that might be a very first question you ask in triage. Does your child have difficulty with medical appointments? And that should trigger the system to provide some, documentation to help support that patient. And don't be afraid to think outside of the box. And again, this is where I put this, do we do this because we have to or because we typically do? Are transitions for a child difficult to get on top of the medical bed and they spend all day sitting in a stroller? Do they have to be on the medical bed, or can we do what we need to do in the stroller where they're more comfortable? And then really important is that a crisis should only occur once. We are always going to try things that might fail and might result in emergence of challenging behavior. But after that occurs, there should be a time for debriefing with teams that I feel is really important and often overlooked, so that you can talk about what went good, what went bad, and create a plan for the next interaction with that patient. Overarching is really to determine the goal. And I didn't know kind of who all is on this call and what particular environment they're working in. So the biggest thing that I always think of is, what is the emergent need? And basically this first question about whether or not a patient needs to complete the appointment or procedure today, looking at emergent versus routine or exploratory. And that's really going to help guide kind of what we need to do next. And when I go to consult, it's the first question that I ask. And if the answer is yes, this child has to get a blood draw because we have to check levels for them to be admitted to an inpatient facility, then the plan needs to include all of those preventative strategies all the way through crisis management. And typically that means we're going to try things like giving them the iPad. We're going to try to get their favorite snacks. We're going to let mom be in the room. We're going to let them be in their preferred seat. Whatever you can do in terms of protocol deviation to try to reduce challenging behavior. And if it were to occur, we can't back off because it's an emergent need. Most of the time that crisis planning comes in with therapeutic holds or the use of some kind of chemical restraint. And so knowing plan A through plan Z is really your best bet, so that it's not a crisis event when it happens. It is part of your plan for care for that child. If the answer is no, be okay with ending the appointment or delaying the procedure before that crisis and try again with another plan. If having access to the iPad as soon as you get to that child with the tourniquet is starting to exhibit some precursors to challenging behavior, be okay with saying, all right, team, we're going to back off and we're going to think about this some more, maybe talk with the caregiver and see what we can do to come up with a new plan. In the emergency room, I know this is tough because kids need to move in and out of there quickly. It is not a place where you want a child residing, but if all of you have experienced things like me, they are likely going to reside there until all of the medical work has come to fruition. And if that child has to be chemically restrained, it's going to delay that process even further. And so if we can take a step back and come up with another plan, it's often best for the patient, so that we also don't initiate another aversive experience that might make the medical setting more challenging in the future. So just a few takeaway messages. I think I'm right on time, which is so unlike me. Caring for children with ASD needs to be tailored to the population. And I'm sure you all know that, but a lot of the times we're talking about at an individual patient level. Prevention can go a long way, but we know that challenging behavior is a really significant barrier to kids with ASD meeting their medical needs. There are solutions being developed. Oftentimes it's intervention. It's really, time consuming, and it takes a long time to work on medical compliance. But if you have a particularly complex case, a lot of the kids that I see at the hospital are return kids, and we all know who they are. Be prepared to consult with people outside of the hospital. It might be behavior analysts, my email is always open to figure out if there are greater needs for these kids that we can work on a multidisciplinary approach for. And that's all I've got for you.
Thank you. Yeah, if you can stop sharing. So, okay, I have a bunch of questions, but I'll open it up to everyone else first to see if they do. And then if there are none, I have many. But just to, again, make it relevant for everybody, because I know like all the clinicians and others on this call don't necessarily work closely with a hospital system that has inpatient and that type of needs. But I just think it's relevant because we're being called on more and more to consult in these cases and to use your expertise, especially these days. I don't, again, I live on a psychiatric campus here. Okay, I'm not an inpatient. I live here in terms of my faculty appointment. And like, we're overwhelmed. I mean, because of COVID, burnout, I mean, we are at twice our capacity. So we're seeing so much of this. And we have kids with autism, young adults with autism that have been on the unit for over a year. I mean, and I think that's what prompted the listserv to ask this question is like, wow, like the units don't know what to do. So like, before I get to my questions, let me open it up. If anyone wants to either unmute and ask your question or raise your hand and unmute, however you want to do it. Does anyone else have specific questions for Michael and Alexis? Nuri asked, or put in chat, and I'm happy to read it out. Nuri asked, has MAP been translated into other languages? Great question.
We have not translated it into other languages, but it's something that, someone could do as long as they just kind of gave credit to the two sources and said it's translated from da. We have no problem with that. We wanted to reach as many people as possible.
Yeah, okay. And before I call on Elizabeth, that was one of my questions. This is shareable, is my understanding, right? You like we can use it, we can download it, we can, because I know it has your logo on it. Is it okay if we put our own logo on it to use in our hospital system?
Yes.
Thank you. Okay. Michael said yes, and this is being recorded, so we're good. Okay. Elizabeth, what is your question?
Hi, yes, thank you for this presentation. It was wonderful. So I actually do 100% of my work in the medical environment, managing challenging behaviors and working with our medical staff all across the continuum for managing our patients in the inpatient environment. So thank you again for this presentation. I was curious if you could speak a little bit to helping staff understand the rationale of prevention versus reactive strategies. I find that one of the biggest challenges I run into is really trying to help staff understand why it is that we want to prevent and why it is that we don't only care about once this child's at a 10 out of 10. Okay, now what's the magic word that we can say to get them to calm down? I was wondering if you've found anything useful in your practice.
Elizabeth, will you remind us where you're from too? Just when you.
I'm at Texas Children's Hospital in Houston.
Yeah, that's a very good question, and I would say that it is an ongoing effort, and patient by patient. All of the staff at Children's where I do my consultation have gone through the Marcus Crisis Prevention Program. It is a manualized training for the prevention and behavioral management of patients. Not just with autism, but really had a heavy focus on how do we de-escalate patients in general, but has some additional training on working with kids with developmental disabilities. And in that, education provides a lot of didactic training on why preventing crisis is more important than, dealing with the crisis once it happens. And I would say that's part of the legwork. Really, the rest is a boots on the ground effort. The first time there is a child in a unit that takes a lot of resources or hurts people, and you get a behavior plan on board that prevents that from happening again, those people then learn, I think, and understand the importance of prevention. What I always tend to focus on is just how lengthy and intensive treatment for challenging behavior is and what the purpose of the admission is. So even if it's an inpatient unit, the purpose is to get that child stable. And I might be overstepping my bounds, but not necessarily to treat challenging behavior from a behavior analytic perspective, and focusing with them on how intensive that is and what really the goal of the admission in the hospital is, and making sure that those are while they are on the same continuum, they are discretely different. Your role is to really get that child to the next step down of assistance, meaning a community provider or some kind of outpatient treatment, and getting them stable is really the goal of an inpatient admission. It's challenging. What we've done is identified a group of behavioral and mental health nurses, techs, and sitters that have advanced training in these topics. And I think by default, want to work with this population. There are different reasons why people got into medical care. I don't think anybody got into that business to get beat up. I chose severe behavior because I'm like that, and I don't mind it. But nobody really probably went to medical school to say, I want to care for a child who's going to try and, hit me or hits themselves repeatedly. And so those specific individuals that now are a team of behavioral and mental health specialists are called in to deal with those really challenging cases and provide, I think, more systemic support for those staff members that work in the PICU or that work, in a generic inpatient environment. And that has been really helpful. Now, I know every system doesn't have that resource, but looking towards defining a group of people that are interested in working with this population has been really helpful.
Thank you. Maybe I'll try to connect with you offline. I have many, many questions, but I want to let other people ask questions.
Absolutely.
Other questions? Let me ask one while other people consider if they have questions or not. Is this in your EMR? Have you considered putting this in Epic or Cerner or whatever you guys use for your EMR?
The coping plan is in Epic for our patients. I'm not sure about Emory.
What about the passport? Is that also in your medical record?
That is not in the medical record right now. Most of our services are not part of the Emory healthcare system. We're more the university system. And so it's there again so that people can bring it, and then whoever they see could put it in the medical record. But since it's being updated constantly based on what's going on, sometimes it may get kind of lost in there. Now, is it something we probably should put in for everyone who comes to Emory? We could talk to them about it, but as people know, kind of going from a university to a healthcare side can have its challenges in getting to that. And Emory's actually switching over to Epic now, and so everyone's just learning Epic. So to then say, here's something else we want you to put into it may be a little difficult. But
yeah, and I would say our Epic builds are like years behind, I think, what everybody's trying to do. So the end of the list gets piled on to the more emergent needs of the healthcare system. But it's been a 5 or 6 year project with the coping plans through Epic that really are now just kind of a standard approach to patient treatment in the Children's Hospital.
Okay. Yovia had asked, could you share more about the residency training?
Well, at the Autism Center, we are one of the rotations that the residents come through. So depending on what department they're coming through, they may be coming for like a half-day visit. They may be coming for a month-long rotation. It just really depends on what department they're coming through and what the goal is for them. Now, since most of our programs are still remote, the training has been kind of up to the program that they're going to be with. We do serve children through adults, and so we try to give every resident experience with all ages. The hands-on training we try to do, especially like in our preschool program, is more like just learn some basic things that you can do. So when you mention to a parent their child has autism, you can give them here's something you can do, and not just like as parents before used to say, I got handed a book and said my kid has autism, and then the resident or the doctor walked away. But here's like, your child has autism, here's some ways you could build language, here's some ways you can incorporate this, here are some resources for you. So really trying to get them to see that autism, how it looks across ages and within individuals. And we have most of our programs are inclusion oriented, so they get to see kind of what is the difference between autism in typically developing kids, especially at the young ages, and knowing that typical development is wide when you're younger. So it's really focusing on that sort of thing. And then how do you positively work with parents throughout that whole process?
We're getting some good questions in the chat now too. So before I ask the next one, can I ask you, because you had that slide with the links, with the email links in it, would you be able to, after this, we hang up on this, to send that to me, or to send it to Idealist, or just so we have, you probably did this before, I remember,
Okay.
like when, just after this talk, it'd be nice
Yeah.
to send that with the links available in an email too. That'd be great.
Yep, I can do that.
Okay. So Elsa said, I work as a hospitalist and we've had a lot of staff turnover. How do you implement educational training and what kind of support do you offer staff after a moment of crisis? And let me build on that too, because I had the same question, but like, I think Alexis, you already like touched on this. Do you intentionally build champions, if you want to call them that, in each area that might be more long-term, or have like, how do you deal with that? So.
Yeah, so there is definitely a tiered approach to training, and it's really based on the likelihood that that individual staff member will encounter a child with challenging behavior. And so, for example, our ED staff are frontline, and they most often see these patients prior to them being on the floor. And so those individuals have, pardon me, the tiered system, maybe they're a tier 1. And so they get all of the training, and it's ongoing at a more a higher dose of training each year in order to maintain that certification. And then individuals who may not have a lot of interaction with those patients, mostly those that like, registration or, general peds floor, those individuals get a lower dose of that particular training. Now, we have the same problems with staff turnover. And so it is a constant train and retrain, but the hospital inside of our initial rollout did identify what you could call champions or trainers inside of the hospital. And so each unit has a trainer that is assigned. And now as we've developed more behavioral mental health specialists, there are several trainers for each unit that are available to do in the moment training, spot checking, looking at integrity of implementation. And they are also the ones that typically run the debrief, which is how we're providing support for those staff members following a crisis event. It really happens kind of right outside the patient room, grabbing everybody that's available that doesn't need to run to a new patient and saying, all right, let's review what just happened. People can give their account, they can express. I think it depends on if we're talking about, having an emotional reaction to challenging behavior, because that definitely exists. Or if it's about, what do we need to know at the moment to prevent a crisis in the next, iteration of interacting with this patient. So that's how we take that approach. There is a lot of work ongoing because of, recidivism and moving out all these patients and new people coming in all the time. There's no perfect system, but really having that tiered approach has been super helpful in terms of the training program.
Quick question, do you require all those trainers and or champions to go through like, what is it, CPI training or whatever training there is out there? Or?
Yeah, so it's called, our specific training for our system is called the MCPP, Marcus Crisis Prevention Program. It is another version of a behavioral management system like CPI or Safety Care. It was actually developed by several individuals, working with children with challenging behavior and developmental disabilities, martial artists, a lot of different people were involved in the inception here at Marcus, and takes more of a least to most approach to managing challenging behavior. Safety Care and CPI are heavily focused on manual restraint and on verbal de-escalation. And what happens with our population is that verbal de-escalation is oftentimes not the most appropriate approach, and they didn't teach an alternative. So MCPP was really developed in order to kind of hit those deficits. But yes, they all go through that training.
One last question from Casey. She asked if do you adjust the strategies for teens, and if so, how, who might have different, behavioral markers, if you will?
Yeah, I mean, every kid is different. It depends on the particular presentation of that teen. I mean, you want to build rapport with a lot of the kids who end up coming in and have kind of run the roost. But the hospital is a different environment than the home. And so what I often see is sometimes the hospital is a preferred location for that individual because they do have control. And so you're not having to deal as much with some of that, response to the parent that they're typically getting at home when they tell them to turn off the TV and start to do homework. None of that stuff is present in the hospital. And so they kind of like being there. And that's also an issue. Kids engage in challenging behavior at home, end up going to the hospital where the world is their oyster. And we make it that way because it helps reduce the likelihood that that kid's going to be in chemical restraint. But there are a lot of things that you can do and adjust, like putting that child on a schedule through the day to kind of maintain some of the control in the hospital while also letting them have some of it. And one to help with the control is offering choices. Choices I find are like our best tool that sometimes we don't use. Do you want to do vitals now, or would you rather have lunch first? Just providing that simple choice can give the illusion of control when the vitals are going to happen regardless, but you can choose the order. It's not really going to, disrupt my day at any point. But yes, tailoring an individual is very important.
Sounds good. I'm always struck by how these principles are the same in basic parenting. We use the same stuff.
Absolutely.
So since Michael's going to provide the listserv with the links, I was hoping, Alexis, can you provide the listserv with some links to the trainings that you just, like several people are putting in chat about those trainings. And I know there are 3 or 4 of them because we did a little research here too, but if you have those and would be able, God, you come on, you're nice enough to give us your time and I give you homework to do. How rude is that, right? But part
That's
of it is
okay with me.
well, it's also a recognition. Marcus is obviously one of the leaders in this area. So like anything we can do to promote, you and also your guys' recommendations would be great. Well, let me say we have like 3 or 4 minutes left. I just wanted to let people know the listserv over the last couple weeks exploded in a couple different subject areas that we are now going to use those as topics moving forward. So this is kind of like the teaser for what's coming up over the next 3 months on this listserv. And I want to remind everybody that, we will have these, it takes about a week, I think now, Angela, to post the recordings on our website, free for anyone to watch. Feel free to share it, whatever you want to do. But again, the school shootings and the stuff that was happening in the country really prompted a lot of questions. And I had posted a question about circumscribed interest in guns. And this became a much bigger issue online, a frightening one on the listserv with the stories that people put out there. But so we're going to have the next topic in July is going to be on, it's like, this should be like the best teaser ever, guns and sex. That's going to be what we're going to talk about on the next idea listserv. That those 2 issues come up a lot. We're going to pursue a couple experts in the field. There's a lawyer that has litigated a lot of these issues in defense of people with autism. And there's some other experts like Rachel Lofton we're going to try to get to come speak to us about those issues. And I think that'll be a really interesting one for us all to hear about. In August, we're going to kind of return to the same area as today, but a different angle because there was so much interest in this. But there was, so Dr. Siegel is going to come talk about weaving together multidisciplinary teams to address challenging behaviors and in mental illness in general. Donna Murray, who's these are folks who are trying to get to come, by the way, they haven't confirmed yet. She's the clinical director of Autism Speaks. They had a big task force, a big summit where they are developing guidelines. So she's going to come talk to us about those. And maybe another person might come speak on that too. And in September, we've had on the listserv, several people said, yeah, tell us more about this Canvas DX and this early T stuff that's coming out on the diagnostic world. There are several different platforms that are coming out. I have my own opinions about these as well, but I'll try to keep my biases to myself and invite speakers who, I love for that one, speakers who can talk about what those are, but also I'd love to have a balanced approach during that webinar too. Like if there's people who are able to speak to, here's the good stuff. I don't want it to be a marketing call. In other words, I don't want people to come say, do this, because what I want people to who are able to talk about it and present both sides, pros and cons of using those types of tools out there. So if you know of anyone for the September call that can talk on both sides of that, that'd be great. But otherwise, I will give you a minute and a half back to your life. It's about a minute and a half to noon here. So thank you so much, Michael and Alexis, for your time and your expertise in this. Feel free, Alexis is gonna, like she said, email her all the questions, flood her email with all kinds of questions, and Michael too, and they're happy to share their expertise. So Thank you all for joining it, and you guys enjoy your summer, and we'll see you in a month. Bye, everybody.